morning. I would like to thank Smile Train and organizing team for the inviting and the opportunity to be here. I don't have disclosure, and today I will talk about what we have learned doing orthognathic surgery in cleft lip and palate patients, especially in the last 5 years, performing around 500 surgeries. Um, What are the complex cases in orthognathic surgery? For us, there are three conditions that make difficult surgeries. First is alveolar cleft without bone graft and great oral nasal fistula, especially in bilateral cleft lip and palate. Second is a severe cant. It's so difficult to correct in orthognathic surgery and maintain stable. And today we talk about severe discrepancy. Uh, in the literature, we have some options to do in this case, like distraction osteogenesis, orthopedic dispositives, bump and hammock, and orthognathic surgery. The distraction osteogenesis should be considered in advanced greater than 10 millimeters, and it's so difficult to control the planar rotations in all planes of the space. We have a relapse around the 20% in the long time, in long follow-up. The average age is 9.5 millimeters, and most patients need orthognathic surgery after distractions osteogenesis. On the other hand, orthopedic dispositives, we have mainly two kinds. One is a bump. We have reduced the discrepancy around the 2.6 millimeters in A point, reduced class 3, and some patients need still going to orthognathic surgery. We have it to hammock is the similar alternative, and we have the average advancing in 2.6 millimeters in early treatment and late treatment around the 5.6 millimeters. The disadvantage is some patients need the orthognathic surgery after this treatment, and when the orthognathic surgery performed in these patients, the median of forward movement is around 6.8 millimeters. Um, the main problem is that even with therapies to correct or reduce class 3, patients still going to orthognathic surgery because the residual growth corrections in the three planes of the space and the mandibular prognatism and middle line desviations and cant in both jaws and not just in upper jaw. Orthognathic surgery is the gold standard for the treatment of maxillomandibular discrepancy. It's possible to correct asymmetries and rotations in all planes of the space, corrected yaw, pitch, roll in both jaws. It's very important we remember that the objective of orthognathic surgery is not just bite. It's necessary to correct the face, airways, bite, all in functions and no pain. This is our example. Is a patient with 21 negative overjet, open bite around 6 millimeters in facial analysis, and in the profile view, you can see the deficiency of the upper jaw and a cant in the right side around 1 millimeters. Look at the occlusal plane. It's so distinct in the upper and lower jaw, and a great discrepancy. And the relation of the upper incisor to inferior molar is the relations in this case. Here you can see the preoperative cephalometric and virtual treatment planning. And after 1 year, you can see the results. The profile is more balancing, and in front of you can see the balancing and the can't correct after the surgery. This is the compare before and after in frontal view and profile view. You can see in this phase our virtual treatment planning. You can compare if the final result is very similar in these patients. The occlusion, the final occlusion, more than 1 year, and the final X-ray around the 5 years post-operative time. In the literature shows that relapse in patients with cleft lip and palate ranges from 10 to 50%. It is directly linked to magnitude of the movement. And of course, we have some relapse, like this case. But in the most case, it's very easy to resolve with minor movement or compensations in teeth movement. Like you can see in this patient in the pre-operate and after 5 years surgery. And you can see the profile pre-operate and after 5 years after rhinoseptoplasty. And in conclusion, we can to answer our initial questions about the orthognathic surgery. Other therapies focus only on the maxilla. Most patients have changes in both segments. In our sample, is around 28% is correct just in upper jaw. In around 6% needed both jaw surgery. The amount of advancement of the maxilla is not enough to correct all discrepancies. These therapies are indicated for a very strict population. In our sample, around 8%, because these patients need more than 10 millimeters forward movement in the upper jaw. It's changed over the time. In the past, this number is 44% of our patients, and today is around 8%. The osteogenic distractions, bump in hammock can be indicated for less than 8%. And if you use 30%, that's the problem is just in upper jaw, it's decreased for 2 or 3% in our sample. The relapse occurs in all techniques. And in orthognathic surgeries, when it occurs, it may have a small orthodontic compensations, and reoperation in our service is very rare. Scientific and technological advancement allow great mobilization of the maxilla in a very nice final occlusion, and this decreases the relapse. And well-defined goals, reproducible planning, and good surgical technique, I think our answer is yes for the orthognathic surgery is predictable in cleft lip and palate patients. Thank you very much for your attention.